So in the first few examples, we're talking about cells that are essentially marked for destruction. But now you can imagine these antibodies, instead of necessarily marking things for destruction, antibodies can also act to bind to things. They can bind to receptors, or they can block receptors. So if we're talking about something like myasthenia gravis, for example, with myasthenia, you can see these receptors, these IgG antibodies, are essentially binding to the acetylcholine receptor here in the neuromuscular junction. So you can see here, these are all going to be your acetylcholine receptors. And here you have your acetylcholine, right? It's traversing the synaptic cleft, trying to make its way to the receptor. But guess what? All of these antibodies are blocking the receptor, which can eventually lead to that muscle fatigue that we talked about in the neurology section, where these patients will typically, especially with the cranial nerves, these patients will tend to have difficult time after repeated motor stimulation. In Graves' disease, this is another classic one where the antibodies not necessarily destroying or marking a tissue for destruction, but instead stimulating a receptor. So with myasthenia, we're blocking the receptor, so we can't stimulate it. Here, we're actually stimulating the receptor using antibodies. So you can see TSH can bind to some of the receptors in the thyroid follicle and cause thyroid hormone production. But we can also make antibodies that bind to the receptor as well and also stimulate the receptor to make thyroid hormone production. And if we make too much of this thyroid hormone production, we end up in a situation with hyperthyroidism. And that's essentially what Graves' disease is, right? Because we're overstimulating the TSH receptor. Just to be familiar with, again, you want to know you have to understand the mechanisms and where these mechanisms fall into these different hypersensitivities. And again, their relevancy. Finally, the last two things on here, we have our diagnostics. So the direct Coombs test. It's very confusing for a lot of different people. So let me just kind of try to explain this. Okay, so you have to understand for each of these tests. So let's just write direct here. So this is going to be the direct Coombs test. So you have to understand for each of these tests what's going on with your host, right? This is going to be your patient. And then what are you adding essentially? Okay, so what's the lab thing that you're adding? Okay, so here's the host and what are you adding? So in this situation, in the direct Coombs test, we're testing for the antibody bound to host cells. So we have a host, let's just say we have our red blood cell here. Let's use the example we talked about. We have some antigen bound to that red blood cell. Okay, and that antigen, these antigens that are on our red blood cell, we have antibodies that are binding to those antigens, right? This is what we just talked about, right? So we have these antibodies all here that are bound to the antigens. Now, this is what we're going to have from the host. What we're adding to the host sample is going to be antibodies to the antibody. So we're adding some kind of anti-antibody. Okay, kind of what we talked about before. And so what this looks like is, so when I add these two things together, these anti-antibodies are going to bind to the Fc portion of the antibodies that are bound to my red blood cells. Okay, and what happens is when I get a bunch of these added antibodies binding, it's going to cause this whole solution to agglutinate, because you can imagine there's going to be other red blood cells here. They're all going to agglutinate, and that's going to indicate a positive test. In other words, we're testing to see if the host has antibodies bound to the surface of the red blood cells. If the host didn't have antibodies bound to the surface of the red blood cells, these blue antibodies, these anti-antibodies, they'd have nothing to bind to, and so we wouldn't get agglutination. So agglutination is going to be a positive test, right? What does that mean? What does it mean that it's a positive test? It means that the host cells have antibodies bound to them, and the anti-antibodies that we added bound to those antibodies. And where do they bind? To the Fc portion of the antibodies bound to the host cells via the anti-antibodies Fab portion. Okay, so I know it's a little confusing, but again, the important thing is in the details. That's what you have to pay attention to. What does the host have, right? What's in the host sample and what are we adding? So the host, we're just going to add the host's serum. And the idea here is if the host has antibodies in their serum, we can add red blood cells potentially with some antigen to see if the host cells will bind to that antigen. Okay, so here's my red blood cell with the antigen. And again, it's not the host's red blood cell. We're adding some external red blood cell with the host's serum. And what happens if I put these together, right? If I put these together, these antibodies are going to bind to these antigens. And what would I expect? I would expect agglutination, right? If there were antibodies in my host serum, which again would be a positive test. And you can imagine the classic antigen that's going to be on red blood cells that we add for doing this agglutination, we might be testing to see if we have red blood cell transfusion compatibility, right? Because different hosts, right, different people will have different markers on their red blood cells, right? If you're type A or type AB, positive, negative, right? And so we might be testing to see if the person that we're going to give this blood to has antibodies to the donor. So we might be seeing if the person that's going to receive the blood, right, that being the host, has antibodies to the donor's red blood cells. That's the solution that we're essentially going to be adding to the host's serum. Okay, so that would be a red blood cell transfusion reaction we would be testing for. We can also do this for hemolytic disease of the newborn, or erythroblastosis fetalis, right? We can test mom's serum, right? In this situation, this would be mom's serum for the antibodies to the Rh factor. Okay, and we can add in red blood cells that are Rh positive, right? So we can use this test, the indirect Coombs test, for things like this specifically. And if you're getting questions on, well, what is this test looking for? Again, we're testing for if the antibody is present in the host serum. If it's present, we add something that we suspect has that antigen. If we get agglutination, we're confirming that the host has the antibodies in the serum. With the direct Coombs test, remember, it's a little bit different. We're looking to see if there's antibodies already bound to the surface of the host cell. So we have to use an antibody that binds to that Fc portion of whatever we think this pink antibody might be. So I know that's a little confusing, but again, understanding the details is critical to getting a lot of these questions right. So just kind of go through this a couple times if you're a little unsure. And a lot of this builds on the previous videos. So if it's a little confusing, go back, check out the previous videos, and I think it will probably make more sense.